to the May 2025 Cure JM Town Hall. We're talking today about tapering medications, essential insights on how, when, and why we taper. As our guest today, we have Dr. Kaveh Ardalan. He is Associate Professor of Pediatrics and the Chief of Pediatric Rheumatology at Duke University. Dr. Ardalan leads the Cure JM Center of Excellence at Duke Children's Hospital, one of 4 national hubs for cutting-edge research, advanced clinical care, and training in juvenile myositis. Widely respected not only for his clinical expertise, but also for his deep commitment to improving the lives of children in this family of families we call Cure JM. Dr. Ardalan, welcome and thank you.
Thank you so much for the warm welcome, James, and thanks to everybody for joining today. And I just, before I get started, I just want to acknowledge some of my colleagues. So Jeff DeVergston, with whom I co-direct the Duke Children's Myositis Center, as well as Lauren Covert, one of the other physicians who is doing excellent basic science research in our myositis center. And then also our chair of pediatrics at Duke, Dr. Ann Reed, who is a very esteemed investigator in the history of juvenile dermatomyositis research. And then our division chief of pediatric rheumatology at Duke University, Dr. Heather Van Mater, all of them very supportive of this work and very appreciative of the support that Cure JM Foundation has provided us at Duke. So today I'll be talking about a really important and at times really challenging topic, which is tapering medications and how we might be able to approach that in clinical care. These are just some disclosures, just in the interest of transparency for work that I've done, as well as research funding. And so basically, I want to just start out with kind of what I think will be the take-home points of this talk, and then we'll kind of dive into how we arrive at these take-home points. But basically, I think that the themes that we're going to hit upon when talking about tapering today are that the first priority for tapering treatment in children with juvenile myositis is going to be tapering their steroid medications, because those are, on the one hand, very, very important, really life-saving medications. And at the same time, they have, in some ways, the most challenging side effect profile. And so the priority ought to be achieving control of juvenile myositis quickly, but then just as quickly trying to figure out how can we get off steroids once we see enough progress to do so. The next priority, in terms of tapering is once children with juvenile myositis are able to continue to get off of steroids, thinking about when and whether to taper other medications, assuming that children are in a state of inactive disease for at least a year off of steroids. And then I think the other themes that are going to be important here are themes around shared decision making. So what I mean by this is that there is not like a study that says to us as doctors, here's the one right way to start and then taper treatment for kids with juvenile myositis. I think maybe one day we'll arrive at something closer to that, but that's not where we're at in 2025. And so because of that, it's really important to take the knowledge that physicians have and really bring that into conversation with the deep knowledge that patients and their family members have around what it's going to mean to either continue versus taper certain treatments, balancing what's known and unknown about the risks and benefits of doing such things, and really thinking about the mental health and quality of life aspects of these decisions. And then the other big theme is balancing the risk of flare when decreasing total medications versus the risks or difficulties of continuing on certain treatments. And recognizing that even those patients who come off all of their meds might still flare eventually. And so it's not as straightforward as getting JM under control and coming off all our meds and everything just being completely straightforward after that. This condition, living with this condition, is a bit of a roller coaster ride, I think, and it can be a roller coaster ride even at times when things seem to be going really, really well. So let's kind of get into some of the details, though. So the first thing, this is maybe just kind of level setting for everybody, but I think that most people at this time are pretty aware that there's what we call early intensive treatment paradigm for taking care of kids with recently diagnosed or newly diagnosed juvenile myositis. And I'm often going to focus on juvenile dermatomyositis right now, mostly because that's what most of the scientific literature that I'm going to cite kind of speaks to. But for those whose children have other forms of juvenile myositis, just know that overall the broad concepts I'm going to talk about today are applicable to all kids. So the early intensive treatment paradigm, what does that mean? The idea is basically when kids are diagnosed with JDM, you don't just start like a little bit of medicine and then if they're not responding, go up a little at a time, a little at a time, and a little at a time. Because if you're doing that, you're basically chasing after the disease constantly, trying to get it under control rather than just controlling it up front and then tapering medications off, which is an approach that seems to be associated with better outcomes. And so when thinking about what early intensive treatment means, usually it means that, children who are recently or newly diagnosed with JDM are going to receive some form of high dose steroids. Sometimes that's primarily by mouth, sometimes that's through an IV and by mouth, just depends on the kid. And then methotrexate is usually the medication that's first given to help continuously control JDM as well as facilitate getting off of steroids and not flaring. And another medicine that often is started either at the time of diagnosis or not long after, if you find that it's necessary, is IVIG or intravenous immunoglobulin, which is an infusion medication that's also pretty effective for the care of kids with JDM. So this is pretty straightforward, and most providers really ought to be practicing this way, with this sort of combination of tools up front. But after that type of treatment starts, what we find is that there's a lot of variability that comes next. So what do I mean by that? What I mean is that different kids with juvenile myositis follow different paths as they start their treatment. Some respond really quickly to treatment, and both their skin and muscle disease responds relatively quickly. Others, maybe their skin is much slower to improve than their muscle disease. That's actually quite common and has been shown in some studies. And these graphs are basically kind of getting at this idea that however you model it, different patients kind of progress on their treatment at different or improve on their treatment at different paces. And in this middle figure, what you can see is the MDAS stands for muscle disease activity score. The SDAS is skin disease activity score. And those scores change at a different pace. Skin tends to be slower to improve than muscle. And so what's tricky then as a physician when you're trying to think about, well, how fast am I going to taper my patient, is that you can't really know 100% upfront how fast your patient is going to respond to treatment and therefore how fast you can taper treatment. And so you're trying as a physician to constantly tailor what you're doing to your patient while also recognizing they may follow a path of their own that's very different than the next kid you're about to see in clinic. And so, there is a little bit of information that helps us kind of see into the future and imagine who might be the kid who's going to have a tougher time coming off meds and who might be the kid who has a relatively easier time coming off of meds. So some of the things that might predict better and sooner improvement would be if in the first place, when you're first diagnosed, that the disease is less severe at the time of diagnosis. Kind of makes sense. If it's milder JDM, then it should hopefully get better faster. But regardless of how severe the disease is up front, if you see a faster pace of recovery in one kid within the first 3 to 6 months of their treatment compared to another kid, the child that is responding more quickly in those first few months is more likely to continue responding well thereafter and probably is going to tolerate a taper that's a little bit faster. And then the other thing that's really important, and this is a place where I really want to applaud the efforts that folks in CureJam have been putting together on this front. Sooner diagnosis and treatment. The sooner kids, the less time there is from when kids first develop JM symptoms from that time until when they start proper treatment for their JM. As long as that time is as short as possible, you find that the outcomes tend to be better. Whereas if there's like a long gap where a kid's had symptoms a long time, hasn't received a diagnosis or hasn't gotten on proper treatment in a long while, you find that that kid is going to have a tougher time in general reaching the best outcomes and doing so quickly. The other things that help us have a sense of who might have a harder time coming off medications would be if you've seen like nail fold capillary assessment. So what this is basically magnifying the nail beds and looking at them under magnification to see the shape and the number of capillaries, so small blood vessels that are kind of right up against the cuticle. In kids who are newly diagnosed with JDM, the capillaries are affected in a variety of ways. There are fewer of them than in a healthy child, and the shape of them is really kind of twisted and thickened. you see that those capillaries tend to heal with treatment. And the closer to normal they are at about 6 months into the treatment, the better. But for some kids, you find that even at 6 months, there's still quite a bit of abnormality in those nail fold capillaries. If you're seeing that, then in general, you want to kind of think as a physician, this might be a kid who's going to have a more chronic form of JDM that's a little bit tougher to get under control and keep under control. And you might consider being a little bit more, just careful about how you taper that child. Some myositis autoantibodies might be associated with different paces of recovery, although this is still being studied. And then the other thing that's super important is mental health and quality of life. The trajectories for those, like the paths kid take on that front, may be really different than the disease activity. For example, like we've found in some studies that we've done with support from CareJM that just because kids are in remission, doesn't mean that their mental health is perfect, 100% excellent mental health. Like there can be a lot of residual after effects of living with the worst of this condition. There can be a lot of stress from maintaining your health with this condition. So we also have to think about that as physicians. It's not just about, okay, your skin rash is gone and your strength is back to normal. And how does all of that add up to ensure like high quality of life and, really, really good emotional well-being? So the challenge is clear, I think, for physicians that are trying to think through this with their patients and their families. How are we going to taper medications in a way that's safe, but also precise for each patient and tailored? So some of the common questions that I think we get as physicians caring for kids with JM from families. How can we get off steroids as soon as possible, but not too soon, right? Because if we taper too quickly, we might flare. But at the same time, I think everybody would agree we'd love to get off steroids as soon as we can. And if we've been able to come off of steroids, what can we taper next? Do we have to be on all these other meds indefinitely, or could we, one by one come off of other medications? If we're thinking about tapering, what's the right time to start doing so? And the reality is there's not a published correct way to approach these questions. There's not even that much data on this topic, but for today's talk, we'll explore some of these considerations and some of the data that is available that guides at least my approach to tapering. And I think maybe one could say most physicians who take care of kids with JDM's approach to tapering. So the first thing is just to talk through, like, are there some published approaches to tapering in the first place? And I'll kind of share a couple. So this one comes from the Childhood Arthritis and Rheumatology Research Alliance, or CARA, which is a major organization of it's an organization of all the major pediatric rheumatology centers in the US and Canada. Duke is a site, for example. And one of the efforts that has been undertaken by CARA is developing what are called consensus treatment plans. So the idea behind these is, there has historically been a lot of variability in how pediatric rheumatologists treat kids with JDM. And you could imagine like lining up 100 pediatric rheumatologists, asking them, how do you dose steroids for your kids with JDM? And there have been times when you might imagine getting 100 responses back. And there's no good way to compare, different people's practice if there's that many different ways they're practicing. So the idea behind consensus treatment plans is to say, within the community, can we come together and identify a couple of ways that we all could agree to treat our patients? And if we do that, then maybe we can actually do studies that compare those, say, 3 or 4 ways of treating rather than 100 ways of treating, and then determine what is the best way of treating kids with JDM. So as part of that effort, there was a publication where kind of consensus around how to taper steroids for newly diagnosed moderately severe JDM patients was published. And here, what they talk about in the publication is, first of all, what are the criteria for starting to taper steroids in kids with newly diagnosed JDM? And this seems pretty straightforward, but they did spell it out clearly that you want to see improvement in strength, you want to see muscle enzymes, so blood tests improving, you want to see rash starting to clear. And then they left a little bit of an open-ended kind of clause here, which was additional criteria that vary depending on patient and physician factors. But I think that's where you can kind of fold in quality of life concerns or involvement of other organs besides, muscles and skin, if that's an issue for your patient. Then they kind of talked about, well, when do you initiate the tapering or the weaning process for steroids for these newly diagnosed patients? And of course, the first criterion is that they need to be improving in the ways defined above. But the second was to say you want to wait a minimum of 4 weeks after starting treatment before you begin to taper steroids. Once you start tapering, though, if you're seeing continued improvement on a visit to visit basis, you could continue tapering a little at a time every 2 to 4 weeks until you're off steroids. And they actually published this schedule here where you can see like at how many weeks of treatment have we been on, and based on the weight of the patient, how much steroid might you imagine, how much prednisone might you imagine that they'd be on? And the goal, that they sort of agreed upon was maybe we could try to imagine getting kids off of steroids by about 1 year, basically. But this approach of tapering in this exact way using the schedule, it should mention it's never actually been formally studied. Like no one has ever, after this was published, like gathered a large group of patients together and looked at, well, if you do this, how do patients do? Can they tolerate this taper? How many of them tolerate it well? And some people in the JDM physician community do wonder how realistic it is for every kid to stop steroids by 1 year, although that is the goal that we have. So we can kind of talk about another study that gives us a little bit of information about rates at which kids come off of steroids after they've been diagnosed. So what this figure is showing us, so this is coming from a study conducted by an international group called PRINTO, the Pediatric Rheumatology International Trials Organization. This is a group of mostly European, but other international sites that came together to do one of the most important randomized controlled trials of in the history of JDM. And what they did was they basically wanted to test the idea about whether or not medicines like methotrexate are helpful in the treatment of newly diagnosed kids with JDM and whether they might help kids get off steroids more quickly. So what they did in this trial was there were 3 groups of kids with newly diagnosed JDM, and they were randomly assigned to different treatments. The first treatment was just prednisone or steroid medicine alone without any other medicine. The second way of treating the patients that they could get randomized to was prednisone or steroids plus methotrexate. And the third was prednisone plus a medicine called cyclosporin. And big picture, what they found is that the kids who got prednisone and methotrexate did the best, both in terms of having the best control of their disease, but also somewhat more favorable side effect profile and able to come down on their steroid doses more effectively than those kids who were getting steroids alone. But one of the subsequent studies they did with the data from this trial is they then actually looked at, they had a standardized approach to tapering steroids during this trial that people had to try to follow for their patients. And so what they could then do is after the trial is done, go back and look at, well, we had this standardized schedule. How did kids do with that? Were they actually able to maintain with this schedule? Or did we find that actually a lot of kids really struggled to come off steroids using the schedule that we thought in advance would make sense for them? And so the way the schedule worked is that the majority of high dose steroids were really given in the first kind of 2 to 6 month period of the trial. Then after that, from kind of month 6 onwards to the end of 2 years, because this was like a 2-year treatment period, they were very, very slowly tapered off pretty low doses of steroids for the kind of 6th month through the 24th month, so the majority of the trial. So bottom line is that kids were on a lot more steroids up front and then quite a small amount of steroid, but for a very long period of time, tapered very slowly. And they were meant to come off steroids by about 2 years. So how did they do? So using a standardized definition of inactive disease, so good disease control, what they found was that about 22% of the patients in this trial were able to achieve remission, so have their disease be fully controlled, stop their steroids using the schedule that was meant to guide like tapering in this study, and not require any other major treatment changes like additional treatments beyond, say, methotrexate to maintain this progress. So that's okay. That's about 1 in 5 kids who, if all they're getting is steroids and methotrexate, they're going to be able to come off steroids within about 2 years. But there's this other group that did not achieve remission, could not really stop their steroids in a definitive way, and did really require additional treatments. And that was 33%. So 1 in 3 patients really having a tough time. And that may tell us that, while we really, really want to get kids off of steroids and we should get them off steroids, just doing only methotrexate or only cyclosporin or like only one steroid sparing medicine may not be enough for quite a few patients. So what in this study predicted, who might come off steroids more successfully was looking at the data, you could actually see that there were some patients that responded really quickly to treatment. They improved a lot in the first 2 to 6 months, and those kids tended in the months to follow to maintain pretty low disease activity and come off steroids on schedule. As far as what predicted clinical remission by 2 years, for those kids who had a very good treatment response in those first couple months, they also tended to be more likely to have inactive disease or go into remission. Kids who are a little bit older, so whose JDM became symptomatic over the age of 8 or 9, they were a little more likely to go into clinical remission too, which is pretty interesting. And then that prednisone and methotrexate group had the best odds of kind of getting into remission by 2 years compared to the prednisone only group and the prednisone and cyclosporin group. So this was one of the reasons why, if you're wondering, why is it that methotrexate seems to be the initial go-to drug? It's because as of right now, it's the drug that we have the best support for using, recognizing that that may change in years to come as new drugs come on the market and we get to compare it head to head with new drugs and see what's hopefully even more effective and hopefully much more tolerable, because side effects can be an issue with methotrexate. So take-home points about steroid tapering from these publications. So I think the first thing is clear. We really should never be giving only steroids as the initial treatment for JDM in this era. We now know that you really ought to be on steroids plus at least one other medicine, and methotrexate for now is the best supported initial choice. I would argue that since we see in that Printo trial data that quite a few patients had a tough time getting their disease under control with just methotrexate and steroids, you should have a low threshold to start something else as well, either at the time of diagnosis or very soon after if you're not seeing a rapid response to treatment. And oftentimes that's going to be a medication like IVIG. Once you're seeing improvement, though, since it's really important to try and get off steroids, try to frequently taper them. So our practice at Duke is to try and have roughly like monthly visits for kids who are on steroids, because we want to have frequent opportunities to see them in the clinic, really evaluate them in detail, do strength assessments, do detailed assessment of their skin rashes. If we need to look at their nail fold capillaries, take a look at that. And by having those frequent opportunities to check whether they're still making good progress, we can therefore make informed decisions about whether we can continue tapering. And if we see that the progress has kind of stalled out, or worse yet, we're seeing signs of a flare, that's an indication to add some kind of other steroid sparing medicine like IVIG or something else on top of whatever else we're doing, so that we can hurry up and get back on track, continue to see more improvement, and get back to tapering steroids quickly. And again, if patients are improving rapidly, taper more quickly. If they're improving more slowly, slow down your approach and consider adding on steroid sparing agents. And still, I think it's reasonable and important to try to have as our goal, like a 1 year goal of being off steroids, but not being surprised if it might take more time for a good number of patients. This is not going to be easy to achieve for many kids, and don't want families to think that it's a failure somehow of their kid or their medical team or themselves if they don't quite get off steroids by a year. It's true north, but we're moving towards it at all times, whether or not we get off right at 1 year or sometime soon after. So what about beyond steroid discontinuation? Like, let's say somebody really gets off steroids, or a kid gets off steroids. What next? Could we imagine tapering other medications? So there's, again, not a lot of data on this particular topic, but there's one study I wanted to highlight that is, to my knowledge, the largest study on discontinuation of medications in kids with JDM. It was a study of a little over 300 patients seen over a couple decades at the National Institutes of Health. one of the crown jewels of the U.S. research environment that deserves a lot of support. And the National Institutes of Health basically has been a longstanding leader in the research for kids with JDM and adults with dermatomyositis. And so for that reason, their program has been seeing patients for many, many years with a lot of follow-up and a lot of very detailed information. And that makes it possible to have this kind of study where you then look backwards in time and say, all right, now that we've got a couple hundred kids that we can comment on, who's doing well and who's not doing well, and how might that influence the way we treat the next generation of kids? So what they looked at is, they basically wanted to see which kids with JDM met certain, what you might call milestones on their JDM journey. So the first milestone is, could they stop their steroids and really stay off steroids for at least, a good period of time, right? Second is, if they're, are they able to have what's called a complete clinical response on medications? Meaning, are they able to get their rash completely under control, get their strength completely back to normal, make sure all other organs are fully healthy on medications for at least a 6-month period? And then the final milestone on their journey was, could they come off their medications and not have any signs of active disease for at least 6 months? And if they achieved that, then that was called remission, recognizing that they couldn't follow patients further out to see if they might flare one day, say 3 years from then. But they were at least looking at, could kids even get off their treatments and stay off safely for, at least 6 months. So, what I want to kind of highlight in this, table down here is that if you look at kind of the bottom row at 60 months, so 5 years out, about half of the patients had been able to really definitively stop steroids. A little over a third had achieved complete clinical response, and just a little under a third had achieved remission. So what that I think tells me is that this process of getting JDM under control and coming off of some or all medications is a marathon, not a sprint. This is not like a 1-year disease or a 2-year disease. This is a disease that, to get it under control and then slowly, carefully come off medications and see if that's going to work for a kid is a very, very slow, steady process. And even with that kind of slow, steady approach, many kids might still have a hard time, completely stopping medications or completely controlling their disease or getting off steroids entirely. So now that being said, keep in mind that patients who are traveling to the NIH for their care might be a little bit sicker than average. And if you look at the total number of patients that were followed at 1 year out versus 5 years out, the numbers decline over time. In other words, over time, fewer and fewer patients go for return visits. You might imagine that those who returned by 5 years are like the sickest patients who still need that kind of level of care. And that may make these numbers look a little bit less optimistic than what you might encounter outside the NIH in a more like typical practice. So this is a pretty busy figure, and I won't really go through it in much detail. I'll just kind of boil it down to the take-home point, which is what they were trying to look at here is, does it matter that you achieve these milestones in a certain order, or not? And the take-home point is that yes, you want to see first if kids can get off of steroids, and also whether they can achieve inactive disease for at least 6 months off steroids, but on other meds. So that complete clinical response. If you can achieve both of those milestones initially, those patients who do achieve both of those milestones have the highest chance of reaching that remission milestone, which means inactive disease for at least 6 months off all meds somewhere down the line. And so what I highlight here in this table at the bottom is in blue, I've kind of outlined, if you've got a kid who really was able to come off steroids and maintain a complete clinical response on medications for a good while, about 2/3 of those patients eventually were able to achieve remission. So maintain some degree of inactive disease off medications. And about a third couldn't quite get there, but those are pretty good odds, all things considered. For those kids who, couldn't get off steroids entirely, couldn't achieve complete clinical response on meds, you see that very, very, very few achieve drug-free remission, right? And so what this kind of tells me is you don't want to rush this process of tapering meds, especially in a kid who still shows signs of smoldering, ongoing disease activity. Because if the disease isn't fully controlled, then, it's almost as though the pot is still boiling a little bit, maybe at a low boil. But, if you kind of peel off different medicines too quickly in a kid who already has some smoldering signs of active JDM, you're likely to see that flare up at some point down the line. And so it may make sense for some kids to at least stay on a little bit of medication for longer periods of time when you're not sure that they're really achieving complete clinical response yet. So some kind of take home messages from this study. So there's not a definitive strategy for steroid tapering that's been proven to be the best way. And steroid discontinuation and medication-free remission, may be possible for some patients, but not always possible for every patient and difficult to achieve for many patients as well. Um, so until we have like a definitive way of knowing who's the kid who can come off their meds, when exactly should they start coming off, how quickly should we do it? What are we supposed to do in 2025 with the sort of kind of incomplete information that is available to us? So I would propose a few different kind of milestones to think through this with. So the first is, at the time of diagnosis, thinking about factors that might help us get us an advanced sense of whether or not a kid is going to do really well and be relatively easy to taper versus whether they might have a tougher time. So, when they're first diagnosed, one thing I think a lot about is, was there a delay to diagnosis? If so, probably want to be a little more cautious with that kid. Do they have really severe disease at diagnosis? Definitely want to be more cautious there. There are some studies that suggest that when you do MRI of the muscles, if you see a lot of fluid in the subcutaneous and fascial tissue, which is basically like fatty and connective tissues that are kind of around the muscle and underneath the skin, that might be a sign of more severe JDM that's harder to control. So I do look at MRI reports and MRI images to see if we detect that. And if so, I think of those kids as needing more treatment up front and maybe needing to be tapered a little bit more slowly. And then depending on the myositis autoantibodies, sometimes I incorporate that into my thinking, although that's probably the one that's like a little bit trickier to interpret. And so, if I'm seeing any of those high risk features, or if in the first like 1 to 3 months of follow up, I'm seeing a kind of slow response to treatment, I have a pretty low threshold to do more intense forms of treatment that might require more IV pulse steroids or IVIG or both. Around the 6 month mark, I kind of try to take stock of where we're at. Have we achieved a pretty low level of disease activity yet? Or do we still see quite a bit of active disease? And are those nail fold capillaries healing? If we're still seeing a lot of active disease or the nail fold capillaries are still not looking like they're on track to heal, thinking carefully about whether we might need additional steroid sparing agents in order to keep coming off steroids. And by about 1 to 2 years, I'm asking myself, have we achieved that clinically inactive disease? Have we been able to come off steroids? And, if during that period of kind of 1 to 2 years out, we're struggling to achieve those milestones, again, thinking about adding on other steroid sparing medications to help us reach those milestones more quickly, not just waiting and watching. Um, and then in terms of, what order in which to taper treatments, because many kids with JDM, they might come off steroids, but they might have required multiple medications like say methotrexate and IVIG, or even more than that to accomplish that. So there's not a lot of guidance really on what order in which to, taper treatments. There's actually really no studies on this. In general, we first, before even tapering steroid sparing medications, we want to see that there's clinically inactive disease in a kid who's been off steroids and that's all been true for at least 1 year before tapering off other medications. Sometimes we'll at least my practice is sometimes I'll taper IVIG a little before that, just because that can be a tough medication to continuously be on month after month. But really carefully doing that if I decide to move forward on that a little bit more quickly. And if we're on multiple agents, like which one do we taper first? So this is where we really need that shared decision making because we really don't have studies that say you should totally, taper methotrexate before IVIG or vice versa. We just don't have data. So to me, it seems like if we don't have data on that, then really what we need to do is see what is acceptable to kids and their families. And what I've often found is that if a kid is on multiple medications to control their JDM, chances are they and their family members feel like there's one that they really do wish they could come off of first. And more often than not, it's reasonable to talk through that and decide together that, yeah, we're going to select that one to be the one that comes off first. If there's some reason why that might not make sense for that individual patient, that's where, as a physician, you can kind of weigh in and make your case. But I really think that more often than not, it's actually good to take some cues from kids and their family members about this because they know what's harder to live with as maintenance treatment. And I think that should be one of the factors we as physicians think about when deciding what to taper off first. A lot of kids and family members will tell us that methotrexate is pretty tough to stay on for long periods of time because it causes, for some kids, really profound nausea and fatigue. Probably about half of kids actually run into issues like that. And there's actually a survey that can be administered to parents and to kids called the methotrexate intolerance severity score, which we can actually send electronically to our patients during or between visits to assess, how how intolerable is your methotrexate? And if, the scores are above certain thresholds, we really start to think to ourselves as physicians, like, this sounds tough. This sounds tough, for any person to go through. Maybe we want to have a conversation proactively about whether this is a sustainable treatment. Um, and then, the other shared decision-making considerations, things that as physicians will bring up and I think patients and family members will bring up is, how severe was JDM when it was first diagnosed or when it last flared? Sometimes knowing how bad it can get informs how much risk we're willing to take to taper. How quick or how slow is the response to treatment? If someone has a form of JDM that takes a really long time to respond to therapy, they may have a different opinion about how quickly and how much to taper their meds by than somebody who has a pretty quick response to treatment. And were there any severe, or have there ever been any severe organ specific manifestations, heart problems, lung disease, severe gastrointestinal disease? Those things should play into our kind of tolerance for, risk tolerance for like tapering treatments. The risk of calcinosis is probably different in each patient, and that needs to be weighed carefully because we think that the more well-controlled the JDM disease activity overall is, the lower the risk of calcinosis. And so, thinking about that for patients. And then the nail fold capillaries, have they healed at or beyond the 6-month mark to a pretty good level, or are they still looking pretty abnormal under magnification? That may be one other factor that we think about. And then, what we call biomarkers. So, blood or other markers that might tell us, the disease is starting to perk up again. The truth is, we don't have great biomarkers right now that can predict a flare while we're tapering treatments. Every once in a blue moon, we'll see muscle enzymes go up before an overt flare, but that's kind of the exception more so than the rule. There are a lot of great researchers who are currently receiving funding from CureJM and other sources to discover and validate better biomarkers. And I think we're going to see that certainly in our lifetime and hopefully very soon. And then occasionally I'll meet a patient who, for various reasons, their strength exam may not be reliable. For example, kids with major developmental delays where they never have been able to walk, yet they have JDM. How are you supposed to do a strength assessment in that kid and know what their full capabilities are after doing a lot of treatment? MRI can be helpful as a tool for assessing muscle inflammation in those kids and making sure you've really controlled their disease before you start tapering. And vice versa. I've had some patients who are super high level athletes with JDM where they are feeling in their muscles that they're achy and fatigued, but you do strength exams on them and they seem to be acing it. And yet, if you do MRI for some of these patients, you actually might sometimes detect some muscle inflammation that's showing up. And so I think it's really important to listen deeply to the patient, that's telling you, I'm serious, I'm tired, and my performance, in track is starting to suffer a little bit. I know I'm acing the strength exam, but I think something's going on. Go ahead and get an MRI because that may be a useful biomarker of disease activity that informs whether you should continue tapering or if you should pause and temporarily go back up on treatment. And then thinking about, what side effects are we experiencing or have we experienced from steroids or other treatments that may inform how quickly we might want to come off versus how much we want to risk coming off at, steroid sparing medicines, because the consequence of doing that might be a flare that requires steroids. And are we willing to go through that again if that happens? Mental health and quality of life impact of flares has to be considered alongside the mental health and quality of life impact of the actual treatments we're using to prevent flares. And so balancing that. And I also try to think about life circumstances and transitions. So like, for some of my patients, that might be a little bit older. They might be starting high school. They might be starting college. They might be starting their first job. And I'll ask them, is this the time where you want to keep tapering, or do you want to pause for a little while, get your feet on the ground in your new roles or your new environment, and then reassess, if you're ready to kind of continue tapering again. And, it's amazing actually, if you ask patients these questions, some will tell you, I want to go full steam ahead on tapering, and others will say, I would actually like to pause right now. And everyone is different. So you won't know as a physician unless you ask. And I think for families and kids and young people, you should bring this up if you're not being asked. The last thing that I just think about, and it's really a big unknown, is if we have a flare because we've been, tapering treatments, how likely are we to get it back under control with the treatments that worked before? We call this disease recapture. And the truth is, sometimes a flare happens and you start back up treatments that worked the first time around for controlling JDM, and you find that this flare is not behaving the same way, and that you're needing to either intensify or change your treatment approach to really get this flare under control. That can be really difficult for some patients and lead to a lot of intense treatment to get it back under control. And so just remembering that, when flares happen, there's no guarantee that prior treatments will work just as well the second or third time around. And asking ourselves, how do we feel about that? Do we feel okay tapering still, or does that give us a little bit of pause? And again, every kid, every family is different when they think through this with us. And I think as physicians, we need to fold in their level of comfort with these decisions and their consequences as we decide together. Last thing that I just want to highlight is for those kids who do really come off all treatments, they may still encounter JDM flares. And it may happen many, many, many years after going into disease remission and coming off all meds. Here is just one example from the 1980s that was published of a kid who had apparently a really easy course of JDM. And after 8 years of inactive disease and almost 4 years of being off all meds, they flared. And so the risk of flare is kind of always lurking in the background, even when things otherwise seem to be smooth sailing. So how to think about that? And again, every family, every kid, I think, approaches this unknown differently. And as physicians, we need to understand what each kid and each family feels about this as we make decisions together. So I think this is all kind of repeat, but basically tapering steroids early and often is important if we can. Adding steroid sparing agents can help us get there sooner, get off steroids sooner. Prioritizing tapering steroids first is really important while leaving other treatments on board until we've seen that the disease stays inactive off steroids for at least a year. And then using shared decision making as a kind of approach for planning how to taper off other steroid sparing agents once the time comes, recognizing there's just a lot of unknowns. And this is hard stuff, and the outcomes are uncertain, and we have to just be honest with each other about that and think through it together with sensitivity. And so I thank you guys for your time today, and thank CureJM for all their support. Thank you.
Thank you so much, Dr. Ardalan. That is remarkably encouraging. I am especially encouraged by that idea that we are collaborators with you, with the clinicians who serve our kids in finding the best course for treatment. And I'm encouraged to take a more active role in our own process in communicating with our doctors about what is working best for my kid. Let me let you know about some things that are coming up before we end today's session. First, coming up on June 4th at 2 Eastern in the afternoon, Our next Cure JM Town Hall is a JM 101, everything that we know about juvenile dermatomyositis in 2025. That's with Dr. Stacy Tarvin. Stacy is at Riley Hospital in Indianapolis, Indiana. It is a remarkable opportunity for us to have Dr. Tarvin with us to discuss those foundational basics of everything we know right now about this pernicious disease. Also, if you're viewing this video before the 2nd of June 2025, you still have an opportunity to register for our National Family Conference. It's coming up quick and registration closes even quicker. So go to curejm.org/conference to find out how you can plug your family into the CureJM Family Conference. Also, you'll find on our website the clinical trials that are currently enrolling patients. There are 3 active clinical trials at the moment that you might be eligible to participate in: CAR-T, CAR-NK, and anifrolumab. You can find more details about the clinical trials currently enrolling at curejm.org/clinicaltrials-2. Lastly, I'll let you know about a couple of our Mom Connect, Grandparents Connects that are coming up here in the next few weeks. May the 22nd at 3 p.m. is a Connect for grandparents. Mom's Connect is May 26th at 8 p.m. Eastern. You can find out about all of those and the ones happening every month by visiting curejm.org/events. One final word of thanks to our corporate sponsors. This has been the May 2025 CureJM Town Hall.